Part 1. The Field of Pediatrics. Chapter 1. Overview of Pediatrics. Pediatrics is the only discipline dedicated to all aspects of the care and well-being of infants, children, and adolescents, including their health, their physical, mental, social, and psychological growth and development, and their ability to achieve full potential as adults. Pediatricians must be concerned not only with specific organ systems, genetics, and biologic processes, but also with environmental, psychosocial, cultural, and political influences, all of which may have major impacts on the health and well-being of children and their families. Children cannot advocate wholly for themselves. As the professionals whose purpose is to advance the well-being of children, pediatricians must be advocates for the individual child and for all children, irrespective of culture, religion, gender, sexual orientation, race, or ethnicity, or of local, state, or national boundaries. The more politically, economically, or socially disenfranchised a population is, the greater the need for advocacy for its children and for those who support children. Youth are often among the most vulnerable persons in society, and thus their needs require special attention. As segmentation between nations blur through advances in media, transportation, technology, communication, and economics, a global, rather than a national or local, perspective for the field of pediatrics becomes both a reality and a necessity. The interconnectedness of health issues across the world has achieved widespread recognition in the wake of the Zika, Ebola, SARS, and AIDS epidemics, war and bioterrorism, the tsunami of 2004, the earthquake in Haiti in 2010, the displacement of families during the Syrian refugee crisis in 2016 to 2018, and the growing severity of drought, hurricanes, and cyclones brought about by climate change. More than a century ago, pediatrics emerged as a medical specialty in response to increasing awareness that the health problems of children differ from those of adults, and that a child's response to disease and stress varies with age and development. In 1959, the United Nations issued the Declaration of the Rights of the Child, articulating the universal presumption that children everywhere have fundamental needs and rights. Today, an affirmation of those rights and an effort to satisfy those needs are more important than ever. Vital statistics about children's health globally. From 1990 to 2010, the world population grew at an annual rate of 1.3% per year, down from 1.8% during the prior 20-year. This rate continues to decline. In 2016, the growth rate was 1.13%. Worldwide, there are 2.34 billion children 18 years and younger, which accounts for approximately one-third, 32%, of the world's population of 7.4 billion persons. In 2016, the average birth rate in the world was 18.5 births per 1,000 population, with a high of 44.8, 1,000 in Niger to the lowest in Monaco at 6.6, 1,000. The most populous countries, China, India, and the United States, have rates of 12.4, 19.3, and 12.5 per 1,000 population, respectively. Despite global interconnectedness, the health of children and youth varies widely between and within regions and nations of the world, depending on several interrelated factors. These include 1. Economic conditions, 2. Educational, social, and cultural considerations, 3. Health and social welfare infrastructure, 4. Climate and geography, 5. Agricultural resources and practices, which account for nutritional resources, 6. Stage of industrialization and urbanization, 7. Gene frequencies for certain disorders, 8. The ecology of infectious agents and their hosts, 9. Social stability, and 10. Political focus and stability. Although genetics, biology, and access to affordable and quality healthcare are important determinants, it has been shown that the social determinants of health, the physical environment, political and economic conditions, social and cultural considerations, and behavioral psychology, play as great a role, if not greater, in health outcomes. To ensure that the needs of children and adults worldwide were not obscured by local needs, in 2000 the international community established 8 Millennium Development Goals, MDGs, to be achieved by 2015. Although all 8 MDGs impact child well-being, MDG 4 was exclusively focused on children, to reduce the under-5 mortality rate, U5MR, by 2/3 between 1990 and 2015. It was estimated that poor nutrition contributed to more than one-third of the deaths worldwide in children less than 5 years old, so many of the efforts to reach this goal centered on increasing household food security. Increasing measles vaccination, particularly in sub-Saharan Africa, was another strategy to reduce the U5MR. There was some progress in achieving MDG 4. The worldwide U5MR decreased by 50% between 1990 and 2015. Although the goal of a two-thirds reduction was not achieved, deaths in children under 5 dropped from 12.7 million in 1990 to about 6 million in 2015, despite growth in world population during the same period. The U5MR can be further divided into neonatal, less than 1 mo of age, infant, less than 1 year of age, and after infancy, 1 to 5 years of age, Fig. 1.1. The leading causes of worldwide U5MR are preterm birth complications, pneumonia, perinatal asphyxia, diarrheal diseases, and malaria. Many of these causes are linked to malnutrition. Children in sub-Saharan Africa are 14 times more likely to die before age 5 years than children in the developed areas of the world. Causes of under 5 mortality differ greatly between developed and developing nations. In developing countries, 66% of deaths in children less than 5 years old resulted from infectious and parasitic diseases. Among the 42 countries having 90% of childhood deaths, diarrheal disease accounted for 22% of deaths, pneumonia 21%, malaria 9%, AIDS 3%, and measles 1%. Neonatal causes contributed 33%. In the United States, pneumonia and influenza accounted for only 2% of under 5 deaths, with only negligible contributions from diarrheal diseases and malaria. Unintentional injury is the most common cause of death among U.S. children aged 1 to 4 years, accounting for approximately 33% of deaths, followed by congenital anomalies, 11%, homicides, 9%, and malignant neoplasms, 8%. Other causes accounted for less than 5% of total mortality within this age group, Table 1.1. Violence is a significant contributor to injury-related mortality in all child age groups, Tables 1.2 and 1.3. Although unintentional injuries in developing countries are proportionately less important causes of mortality than in developed countries, the absolute rates and contributions of these injuries to morbidity are substantially greater. The infant mortality rate, deaths of children less than 1 year old, accounts for 85% of the U5MR in industrialized countries, but only 70% in the least developed nations. Neonatal, less than 1 mo, death contributes substantially as well, growing in proportion as the U5MR decreases. Globally, the neonatal mortality rate of 19/1000 live births represents 60% of the infant mortality rate and 45% of the U5 The neonatal mortality rate is responsible for 56% of the U5MR in industrialized nations, 45% in developing countries, but only 38% in the least developed countries. More children less than 5 years old in developing countries die from non-birth related causes. Across the globe, there are significant variations in child mortality rates by nation, by region, by economic status, and by level of industrial development. The categorizations employed by the World Bank, http://wdi.worldbank.org/table/2.18. As of 2015, 8 nations have a U5MR of as greater than or equal to 100 per 1,000 live births, all in the WHO African region, Fig. 1.2. The average U5MR in low-income countries was 76 1,000 live births, and in high-income countries, 6 1,000. Income and wealth, however, are not the only determinants of mortality. For example, the United States has the 10th highest gross national income per capita, but ranked 57th in lowest infant mortality rate in 2016. In addition to mortality rates, causes of death vary by developmental status of the nation. In the United States, the 3 leading causes of death among children less than 5 years old were congenital anomalies, disorders related to gestation and low birth weight, and unintentional injuries. By contrast, in developing countries, most infant deaths are caused by pneumonia, diarrheal disease, and malaria. The changing pediatric world. A profound improvement in child health within industrialized nations occurred in the 20th century with the introduction of vaccines, antibiotic agents, and improved hygienic practices. Efforts to control infectious diseases were complemented by better understanding of the role of nutrition in preventing illness and maintaining health. In the United States, Canada, and parts of Europe, new and continuing discoveries in these areas led to establishment of publicly funded well-child clinics for low-income families. Although the timing of infectious disease control was uneven around the globe, this focus on control was accompanied by significant decreases in morbidity and mortality in all countries. In the later 20th century, with improved control of infectious diseases through more effective prevention and treatment, including the eradication of polio in the Western Hemisphere, pediatric medicine in industrialized nations increasingly turned its attention to a broad spectrum of non-infectious acute and chronic conditions. These included potentially lethal conditions as well as temporarily or permanently handicapping conditions. Advances occurred in the diagnosis, care, and treatment of leukemia and other neoplasms, cystic fibrosis, sickle cell disease, diseases of the newborn infant, congenital heart disease, genetic defects, rheumatic diseases, renal diseases, and metabolic and endocrine disorders. Until the 1970s and early 1980s, children affected with sickle cell disease often died within the first 3 years of life, often from overwhelming sepsis caused by encapsulated bacteria. In the 1980s, a multi-center study showed that early initiation of penicillin prophylaxis led to an 84% risk reduction for pneumococcal sepsis. Life expectancy for those with sickle cell disease increased when penicillin prophylaxis was initiated early in life. The use of prophylactic penicillin became the standard of care, increasing the importance of early detection of sickle cell disease, which led to expanding universal newborn screening, and paving the way for advances in the chronic management of the disease, including transfusion therapy, radiographic screening for silent cerebral infarctions, and hydroxyurea as a disease-modifying therapy. The success of penicillin prophylaxis likely led to a more rapid rate of innovation in the diagnosis and management of the disease, since children with the condition now had increased life expectancy. Whereas in the pre-prophylaxis era children often died by age 3, now 95% of individuals born with sickle cell disease will live to their 18th birthday, and most will survive until their 5th decade. The treatment of acute lymphoblastic leukemia, the most common pediatric malignancy, has also shown amazing advances. 5-year survival rates have increased from 90% in 2000 to 2005. Cystic fibrosis has shown improvements in survival as well. In the 1960s, most children with cystic fibrosis did not live until school age. With advances in pulmonary and nutritional therapies, as well as earlier initiation of these therapies secondary to earlier identification through newborn screening, a child born with cystic fibrosis in 2010 has a projected life expectancy of 39 to 56 years. These major advances in the management of chronic diseases of childhood were accomplished when significant improvement occurred in the prevention and treatment of acute infectious diseases, at least in industrial countries. This allowed human and economic resources to shift toward addressing chronic disease. The new morbidities. Given the advances in public health aimed at decreasing morbidity and mortality in infectious diseases, immunization, hygiene, antibiotics, along with the rise of technologic advances in clinical care, attention was given to the new morbidities, behavioral, developmental, and psychosocial conditions and problems shown to be increasingly associated with suboptimal health outcomes and quality of life. The American Academy of Pediatrics, AAP Committee on Psychosocial Aspects of Child and Family Health asserted that the prevention, early detection, and management of these types of child health problems should be a central focus of the field of pediatrics, and that it would require an expansion in the knowledge base regarding 1. Physical and environmental factors affecting behavior, 2. Normal child behavior and development, 3. Health behaviors as they pertain to child health, and 4. Mild, moderate, and severe behavioral and developmental disorders. Accomplishing this would require reconceptualizing professional training, improving clinical communication and interviewing skills, expanding mental health resources for children, and shifting time allocation during child health supervision visits to address these concerns. In 2001, the committee revisited this issue and re-emphasized the need to address environmental and social aspects in addition to developmental and behavioral issues, Table 1.4. These included violence, firearms, substance use, and school problems, as well as poverty, homelessness, single-parent families, divorce, media, and childcare. Although this expanding list seems daunting and beyond the scope of what pediatricians typically addressed, i.e., physical health and development, many of these behavioral, environmental, and psychosocial issues, which fall under the category of social determinants of health, account for a large proportion of variance in health outcomes in children and youth. The role of pediatrics in the boundaries of clinical practice needed to change in order to address these salient contributors to child health and well-being. Newer models of clinical care that rely on close collaboration and coordination with other professionals committed to child welfare, e.g., social workers, psychologists, mental health providers, educators, were developed. As this model expanded, so did the role of the family, in particular the child's caregiver, from a passive recipient of professional services to a more equitable and inclusive partner in identifying the issues that needed to be addressed, as well as helping decide which therapeutic options had the best fit with the child, the family, and the condition. The framing of salient child health issues under the new morbidity concept acknowledges that the determinants of health are heterogeneous but interconnected. Biology, genetics, healthcare, behaviors, social conditions, and environmental influences should not be viewed as mutually exclusive determinants. They exert their influences through complex interactions on multiple levels. For example, epigenetic changes that result from specific social and environmental conditions illustrate the influence of context on gene expression. Studies have demonstrated that while each of these interrelated determinants are important for optimal health, development, and well-being, the greatest contributions to health outcomes occur in the behavioral, social, and environmental domains, the social determinants of health. From 40% to 70% of the relative variation in certain health outcomes is caused by social and economic conditions, health behaviors, and environmental factors. Whereas traditional medical education and clinical practice emphasize the biologic, genetic, and healthcare-related determinants of health, the recognition of the new morbidities as a focus of child healthcare provision reinforced the need to address social determinants as a key component of pediatric care, training, and research. The new morbidities. The new morbidities concept brought into perspective the importance of addressing the social determinants of health, as well as the increasing prevalence and salience of chronic physical and behavioral health conditions in pediatric healthcare. Since then, advances in epidemiology, physiology, and epigenetics have expanded the scope of inquiry into the effects of a broad range of health determinants and provided more sophisticated explanatory models for the mechanisms that explain their effects. Table 1.4. Adverse childhood experiences. Adverse childhood experiences, ACEs, are stressful events experienced during childhood that can have profound health consequences in childhood and throughout the life course into adulthood. ACEs were initially defined as abuse, physical, emotional, sexual, neglect, physical and emotional, and household challenges, family dysfunction, parental spousal abuse, mental illness in household, household substance abuse, incarceration of household member, parental separation or divorce. Retrospective studies have shown a graded dose-response effect of ACEs experienced in childhood on the future adult health of the child who experienced the ACEs. For example, more childhood adversity was associated with significantly increased risk in later life of ischemic heart disease, chronic obstructive pulmonary disease, liver disease, depression, obesity, and cancer. People who suffered as greater than or equal to 6 ACEs as a child died almost 20 years earlier than those who experienced no ACEs. While the original conceptualization of ACEs included family-level psychosocial trauma, recent attempts have been made to expand the concept to include macro-level stressors, such as those encountered in the neighborhood and community. Table 1.5. These include witnessing violence in the community, poverty, bullying and peer victimization, peer isolation, living in unsafe neighborhoods, low neighborhood social capital, living in foster care, and experiencing discrimination or racism. ACEs and other psychosocial traumas may influence health through a number of mechanisms. ACEs are associated with adoption of risky behaviors such as substance use and early initiation of sexual activity, which in turn may increase the risk of chronic diseases such as lung cancer, liver disease, obesity, human papillomavirus, HPV, infection and cervical cancer, chronic lung disease, and premature mortality. Childhood trauma can also disrupt neurodevelopment during critical stages and contribute to social, emotional, and cognitive impairment. Finally, ACEs can result in toxic stress and lead to the dysregulation of normal physiologic processes. Toxic stress and allostatic load. The effects of stress are moderated by the intensity of the stress, the biologic response to the stress, and the social and physical environment in which the stress is experienced. Toxic stress occurs when a child experiences stressful events that are chronic, intense, are prolonged, and are inadequately buffered by the child's social support system, most importantly, parents and adult caregivers. Toxic psychosocial stress influences physical health by producing allostatic load, or pathophysiologic dysregulation of normal regulatory systems. Allostatic load is the wear and tear that the body and its regulatory mechanisms experience in response to chronic, unbuffered stress. The systems that can be affected through allostatic load include the neuroendocrine, cardiovascular, immune, and metabolic systems. Dysregulation of stress hormones in the hypothalamic pituitary adrenal, HPA, and sympathetic adrenal medullary, SAM, systems, inflammatory cytokines, hormones, e.g., insulin, immune factors, e.g., fibrinogen, C-reactive protein, and cardiovascular biomarkers, e.g., blood pressure, can occur from chronic stress and result in pathophysiologic conditions associated with chronic diseases. Chronic stress can also have effects at the genetic level. Studies of cellular aging have shown that chronic stress decreases telomere length, a determinant of aging on the cellular level. Epigenetic changes. including differential immune system DNA methylation, have been shown to occur after child abuse and post-traumatic stress disorder, PTSD, contributing to inflammatory and immune dysregulation. Pediatrics, developmental psychology, basic sciences, and public health have contributed significant advances to the study of the behavioral, developmental, and social determinants of child health. The influence of psychosocial stress brought about by environmental challenges, while always acknowledged as important, has taken on a new level of salience as epidemiologists have linked its occurrence to significant morbidities throughout the life course, and as basic and clinical neuroscience has provided a multi-level framework for understanding how behavioral and psychosocial issues get under the skin to cause physiologic dysfunction and dysregulation. Eco-biodevelopmental framework. An eco-biodevelopmental framework has been proposed to integrate the environmental, biologic, and developmental factors into a model of health and illness, Fig. 1.3. This model posits that the ecology, or the physical and social environment, affects biology through the epigenetic and allostatic load mechanisms discussed above. The environment also influences development through life course science, which includes the effects of toxic exposures and childhood adversity on cognitive, behavioral, and physical health throughout the life course. Biology influences development through brain maturation and neuroplasticity, which in turn are also affected by inputs from the social and physical environment. The eco-biodevelopmental framework is consistent with the biopsychosocial model while adding a life course developmental dimension. Chronic illness and children with special healthcare needs. The care of children with chronic conditions has become an increasingly larger part of clinical pediatrics, for both the pediatric subspecialist and the general pediatrician. Children and youth with special healthcare needs, CSHCN, are defined by the U.S. Maternal and Child Health Bureau as those who have or are at increased risk for a chronic physical, developmental, behavioral, or emotional condition and who also require health and related services of a type or amount beyond that required by children generally. According to the 2011-12 National Survey of Children's Health, NSCH, greater than 14.5 million, or 20% of U.S. children, have a special health need. The 2009-2010 National Survey of Children with Special Healthcare Needs, NSCSHCN, reports that almost one quarter, 23%, of U.S. households with children have a child with a special need. The conditions these children have are extremely heterogeneous and include cerebral palsy, asthma, obesity, sickle cell disease, diabetes, learning disability, communication disorders, Down syndrome, heart conditions, migraine headaches, depression, conduct disorder, autism, and attention deficit, hyperactivity disorder, Table 1.6. Most of these children need specialty care in addition to primary care. In the United States, 0.4 to 0.7% of children fall into the category of highest medical complexity. These children account for 15 to 33% of all healthcare spending for children. Children with medical complexity account for greater than 70% of hospital readmissions. 9 of 10 CSHCN have functional difficulties in the sensory, cognitive, movement, emotional, or behavioral domains, Table 1.7. More than 65%, 7.2 million, of CSHCN have conditions that affect their daily activities, and greater than 2.3 million families experience financial difficulties because of their children's special health needs. The fact that 25% of family members of CSHCN cut back work hours or stop working because of their child's special needs highlights the social and economic impact of child chronic illness, at both the individual and the national economic level. Pediatricians are typically the point persons in the professional care of these children and provide data and expert opinion to procure needed services and resources to the child in the clinic, home, schools, and community. Such demands require an efficient model of chronic care. Systems of care. Population health approach. Because pediatric practice is increasingly spent working with patients and families who have chronic issues and conditions, new approaches to healthcare services delivery have been proposed. Whereas traditional practice models concentrate efforts toward the preventive and therapeutic needs of those patients who present for care, a population health approach to care refocuses efforts to emphasize the need to address health from a community or population level perspective, with emphasis on identifying and addressing the needs of individuals and families who do not seek regular care, or whose care is episodic and suboptimal from a prevention or management standpoint. Effectiveness of such a system would increase with advances in collaboration between healthcare providers and payers, insurance companies, to identify gaps in care, data surveillance systems, and electronic health records, EHRs, and with an expanded cadre of healthcare personnel such as care coordinators, nurse practitioners and physician assistants, social workers, health navigators, and community health workers. Healthcare reimbursement modifications, such as incorporating value-based and quality of care-based models, if implemented correctly, may further advance a population health approach to care. Medical home. The concept of the patient and family-centered medical home, PFCMH, approach to providing care has its origins in pediatrics in the late 20th century. As defined by AAP, a medical home provides care that is accessible, continuous, comprehensive, family-centered, coordinated, compassionate, and culturally effective. Patients and family members are key active participants, working with clinicians to identify priorities for and approaches to care. A key aspect of the PFCMH is care coordination. According to AAP, care coordination addresses interrelated medical, social, developmental, behavioral, educational, and financial needs to achieve optimal health and wellness outcomes. A care coordinator is the point person on the team who prospectively identifies the patient's and family's needs, concerns, and priorities for the healthcare visit, gathers pertinent information, lab results, consultations, educational plans, screening, testing results, communicates with subspecialists, and relays all important information to the clinical team before the patient-family visit. After a healthcare visit, the care coordinator works with the family to address any ongoing concerns, directs efforts to schedule follow-up appointments and referrals, and communicates information to all necessary parties. The care coordinator typically is not a physician. The intended result of care coordination is an efficient and comprehensive interaction between the pediatric team and the family, between primary care and specialty care, between ambulatory and inpatient care teams, and between the pediatric care team and the community-based supports on which the patient and family depend. Provision of care consistent with the elements of a medical home has been associated with more accurate and early diagnosis, fewer emergency department visits and inpatient hospitalizations, lower costs, fewer unmet needs, lower out-of-pocket medical costs, less impact on parental employment, fewer school absences, and better patient satisfaction. According to the 2011-12 National Survey of Children's Health, 54.4% of U.S. children received coordinated, comprehensive care within a medical home. Medical and health neighborhood. While the medical home concept relates to practice transformation specific to primary care, a broadening of this concept has been proposed along two separate dimensions. The medical neighborhood expands the medical home concept and refers to coordinated and efficient integration between primary care pediatricians and the subspecialist, including integrated EHRs, efficient coordinated appointment scheduling, and enhanced communication. Such a system has the potential to provide a less stressful patient and family experience and could also lead to cost reduction and a decrease in medical errors. Another expansion and modification of the medial home is the health neighborhood concept. The health neighborhood is based on the recognition of the importance of coordination with community-based and non-medical providers to address comprehensively and efficiently the social determinants of health. Health neighborhoods include the healthcare providers, consistent with the medical home and neighborhood, but also involves services such as early intervention programs, the education system, childcare, community-based behavioral and mental health services, legal services, nutritional support services, and other clinical and community-based services that the patient and family need to access. The health neighborhood team helps families identify the needs of the patient, assists with referrals to appropriate agencies outside the healthcare system, and coordinates care. Some non-medical services may be co-located at the medical office. Medical legal partnerships, MLPs, are collaborations between the healthcare and legal systems and embed legal aid personnel in the medical clinic. These lawyers and legal paraprofessionals can provide direct services to patients and families who have legal issues that may be affecting the child's health, e.g., housing code violations, utility shutoff, food insecurity, immigration issues, educational accommodations, guardianship. In addition to providing direct services, MLPs also train healthcare personnel in the legal and social determinants of health and work with physicians and others to advocate for policy change. Other non-medical health neighborhood services that could be co-located in the medical center include supplemental nutrition assistance programs, parenting programs, behavioral health services, and family financial counseling. Many, if not most, other services are located in the community. The health neighborhood model links families to these services and provides efficient ongoing coordination and communication. Community health workers or health navigators are paraprofessional team members who are community and culturally informed and serve as a coordinating link between the family, the medical home, and needed community services. Community health workers and health navigators can also provide patient and family education. Expanded care models such as these have the potential to achieve what the Institute for Healthcare Improvement calls the triple aim for healthcare, focusing on care, improving the patient experience with healthcare, quality care, and satisfaction. Health, improving the health of populations, and cost, reducing per capita healthcare costs. Fig. 1.4.